The topic of this lecture is Update on Objective Assessment of Hearing in Infants and Young Children. I've been involved in the objective assessment of hearing in infants and young children for over 40 years as an audiologist. So my clinical experiences, my research knowledge is all incorporated into this very practical lecture. The learning objectives for this presentation are listed here. At the end of this narrated PowerPoint presentation, you will have no problem identifying 4 objective auditory procedures that are used in the assessment of infant hearing. You will be able to define the special contribution of otoacoustic emissions in the assessment of hearing in children, and also the special contribution of acoustic reflex measurements in hearing assessment of children and infants, and really people of all ages. And I imagine most of you are not using acoustic reflexes regularly in your test battery. So I hope that this lecture convinces you that acoustic reflexes should be part of your routine assessment of infants and young children. We're going to be covering all of these topics with the exception of one. I'll be reviewing the cross-check principle and how it applies to hearing assessment of all patients, but particularly children. And then I'm going to address the concept of value-added tests that actually contribute to the diagnosis and the management of your patients. If there's a procedure that you could perform that is actually not going to really help you make an accurate diagnosis of hearing loss or other related problems, such as auditory processing disorders, or if that test that you could use is not going to help you in making decisions about managing the patient, then it's really not necessary to perform that test. We should only use tests that add value to the diagnosis and management of our patients. And then I'm going to make the point that objective tests, not behavioral tests, but objective tests, will never mislead you. They'll always give you accurate information. Behavioral tests sometimes will not be accurate for a variety of reasons: neurologic dysfunction, motivation, cognitive decline, other factors. But objective tests always will contribute to the diagnosis and management of your patients. And then we're going to review in this narrated PowerPoint these objective procedures with one exception. The one exception is auditory brainstem response. Now, of course, that is one of the most important objective procedures. But the reason that we are not including it in this narrated PowerPoint presentation is because there is an entire workshop session on that topic, which you will be listening to and viewing at the conference. So let's get started with this topic of objective assessment of hearing in infants and young children. The cross-check principle was first published in 1976, and it is just as important today as it was then. In fact, it's essential to understand the cross-check principle if you're going to be involved in the diagnosis of hearing loss in infants and young children. The cross-check principle was first described by Dr. James Jerger and Deborah Hayes in a publication in 1976. And this is actually the title page of the publication. I would be more than happy to send you a copy of this original article. I do have a copy, but you can probably find it online. It basically describes 5 different cases, 5 cases where the patient initially underwent a hearing evaluation only with behavioral techniques. Then the patients were referred to the clinic that Dr. Jerger directed in Houston, Texas. And at that time, the original diagnosis was found to be inaccurate, wrong. And the 5 cases illustrate how management for children can be very, very, or can be incorrect and even damaging if the diagnosis is inaccurate. This is a photograph of Dr. Jerger on the left and Deborah Hayes, and I think most of you are familiar with the name James Jerger. He is still alive and quite getting on in his years, well into his 90s, and he lives in Portland, Oregon. Deborah Hayes is a very well-known audiologist in her own right, has completed many international presentations and taken a leadership role in conferences internationally. She also was instrumental in organizing a task force, a panel that put together clinical practice guidelines for auditory neuropathy, which I'll mention later. The original cross-check principle was based on this test battery. Now again, this was in the 1970s, and I had the pleasure of actually working in this clinic. Dr. Jerger was my mentor, or is my mentor. So I was actually in the clinic, and I was involved in the evaluation of some of the children who are described in the cross-check principle article of 1976. So back then, most audiologists relied exclusively on behavioral audiometry. So no matter what age the child happened to be, whether it's an infant or a 1-year-old or 2-year-old, and whether the child has normal cognitive function or some cognitive impairment, whether the child had multiple problems such as cerebral palsy or other motor problems, or whether they were strictly had an auditory problem, behavioral audiometry was really the only approach that most audiologists were using. Now, in the early 1970s, admittance measurements, then we called them impedance measurements, had just been introduced. In fact, Dr. Jerger, as I've already mentioned in my earlier lecture, was instrumental in showing that the impedance measurements, tympanometry and acoustic reflexes, were useful clinically. Now, in those years, only contralateral acoustic reflexes were available. Technologically, it was not yet possible to present the ipsilateral stimulus in the same ear that was where the impedance changes were being measured. Also, another technique had just been introduced clinically at this time, the mid-1970s, and that was the auditory brainstem response. Back then, it was actually called brainstem evoked response audiometry. Now, at that time, only click stimuli, air conduction and bone conduction, were available. Tone burst stimuli were not yet had not yet been developed for the equipment that existed at the time. These were the very early years of ABR. But even with this very simple test battery with two objective measures, non-behavioral measures, admittance measurements and ABR, we were able to show that behavioral audiometry didn't always provide the information that was needed to manage the patient effectively. Here are several quotes from the original article. And to summarize, behavioral audiometry, evaluating a child with pure tone audiometry or speech audiometry, did not always yield an accurate diagnosis. In fact, sometimes it resulted in a very inaccurate diagnosis or misdiagnosis. So Dr. Jerger and Deborah Hayes articulated this principle. You really cannot accept the results of any test, no matter what the test, unless you have an independent confirmation of those results. So in other words, if you have one test, say pure tone audiometry or maybe sound field audiometry with speech stimuli in a very young infant, you can't accept those results until those results are confirmed by another totally different test, such as the ABR. And Dr. Jerger went on to say that as long as audiologists are willing to only accept the results of behavioral audiometry, mistakes will be made. And that's what was demonstrated with the 5 cases in this article. And that principle is very much true today. Fortunately, today, 2022, we have a much more extensive diagnostic test battery to evaluate children and even infants. We, in addition to behavioral audiometry, we have otoacoustic emissions, which provide unique information and objective information on cochlear auditory function. Of course, we still have aural emittance measurements, tympanometry, including high-frequency tympanometry, and we now have ipsilateral and contralateral acoustic reflex capability. And we can use tones or we can use broadband noise stimuli, as I mentioned in my first lecture. We also have more options in performing auditory brainstem response, including not only air and bone conduction click stimulation, but also tone bursts of different frequencies, and a relatively new advance in stimuli called chirps. We'll talk more about chirps in a moment. Now, in addition to the ABR, we have the auditory steady state response. The auditory steady state response, or ASSR, provides us with the opportunity to present very high intensity stimuli and to record a response that is automatically detected. It doesn't require visual inspection of a waveform. It's automatically detected and statistically confirmed. We still have electrocochleography. Of course, it's been around since the early 1930s. But most audiologists began to turn their attention to the auditory brainstem response once it became available. So for many years, audiologists didn't record the electrocochleography response unless they were trying to make a diagnosis of Meniere's disease. We now know that electrocochleography is very helpful in the evaluation and diagnosis of auditory neuropathy and in determining the best management strategy for kids with auditory neuropathy spectrum disorder. And then finally, we have available to us cortical auditory evoked responses. Now, we don't record those very often in infants and young children, but they can be measured even in newborn infants. And cortical auditory evoked responses do offer an objective way of confirming that the brain is being adequately stimulated by sound when children are managed with hearing aids or with cochlear implants. If you're interested in more information about the cross-check principle and kind of an expanded version of what I've been just describing, I would be happy to send you this article, which I published in 2016 on the 40th anniversary of the publication of the cross-check principle. Just send me an email and I'd be more than happy to send you a reprint of this article. Okay, so we're going to move on now and talk about an important concept, a concept that I already introduced to you, so I'll go very quickly through this section, and that concept is value-added tests. When we're evaluating a child, we don't have much time. If the child is sleeping during the test, they're not going to sleep for long, and of course their cooperation is usually quite limited. So we should only be administering auditory tests to infants and young children when we know that the results are going to contribute to the diagnosis of the hearing loss in the child or to their management. We don't have time to be administering unnecessary tests that waste our valuable clinical time. So we always have to ask ourselves when we're evaluating any patient, but particularly a young child or an infant, why am I performing this test? What do I hope to gain from this procedure? What information do I need to manage the child? Will this procedure give me that information? And if the answer to any of these questions is no, it's not really going to provide any information, I already have the information I need, then we should not perform that test. So we should only perform auditory procedures, even though we have a large test battery with many, many different tests, we should only perform the procedures that are likely to contribute to the diagnosis of the child's hearing problem, or to confirm that they do have a hearing problem, and to help us make important decisions about management. So, for example, with some children, we really don't need electrocochleography. If we have a child where the auditory brainstem response results confirm normal hearing sensitivity, we can record a clear ABR down to 20 decibels for both tones and clicks, and that same child has normal OAEs, we don't need to perform other tests. They won't add any value to our diagnosis because we already know the child's got normal auditory function. So there are many ways we can determine whether or not a test adds value, but that's something we should always consider as we develop a strategy for evaluating infants and young children. And another important concept, our goal is not just to identify a hearing loss in a child. It's not even just to diagnose that hearing loss. Ultimately, our goal is to improve that child's outcome. We want the child to be communicating effectively, to develop normal speech and language acquisition, to be able to enter school having had the advantage of hearing for the last 4 to 5 years. So although each of these 4 steps is very important, identification of hearing loss through screening, diagnosis of hearing loss, which we're focusing on in this lecture, various forms of intervention, hearing aids, rehabilitation, cochlear implants, whatever is required, even surgery. Our focus should always be on the outcome, the final outcome. Are we achieving our goal of giving this child effective communication, getting them off to a good start in life? And really, having done this for 40 years, diagnosing hearing loss in infants, I can say that there's nothing more important in audiology. You're changing a person's life, and entirely changing their life at the very earliest ages. When they're not even 6 months old, you're able to give them the benefit of hearing, which then allows them to develop speech and language and develop communication effectively, which will be an incredible start for their life. If you don't diagnose the hearing loss accurately, or if they don't ever see an audiologist, they will be forever handicapped. They will be always unable to compete in the modern world because they won't be able to communicate effectively. So this is probably one of the most important clinical activities that any audiologist can be involved in, with lifelong impact for the children that we're evaluating. Okay, I've already made this point, I believe, in the first lecture. Objective auditory tests do not lie. I know it's kind of an odd statement to make, but what I mean by that is that if you have results from objective tests, such as OAEs, oral emittance, ABR, and if those results disagree or are not consistent with the behavioral results, then I would always believe or trust in the objective test results. So if you have a child whose audiogram looks normal, and yet the OAEs are abnormal or the ABR suggests a hearing loss, then they do have a hearing problem, even though the audiogram is normal. We see this all the time. We see patients, particularly adults, who have normal audiograms but clearly have auditory dysfunction, either at the central auditory level or in the cochlea. It's just not being detected with the behavior results. And the reverse can also be true. A patient may show a hearing loss on the audiogram, and without the objective test, if we don't follow the cross-check principle, we could go ahead and manage that child with hearing aids. The child could undergo surgery. They could even receive a cochlear implant, and in fact, they don't have a hearing loss because the behavioral audiometry was affected by cognition or some other factor. There was a mistake in the diagnosis because of a reliance on the behavioral test. So when you have a discrepancy between objective tests and behavioral tests, the first step is to try to resolve that difference and to get to the truth. What is the child's auditory function? But if the discrepancy exists, and very often it does, the behavioral audiometry is going to continue to result in inaccurate findings, then trust the objective tests. There are many advantages of objective tests in comparison to behavioral audiometry. Now, I'm not saying to you that you should discard pure tone audiometry, that you should sell your audiometer, but I'm saying you must always supplement or confirm your behavior results with the results of objective tests. And that allows you to evaluate newborn infants and young children who cannot really be completely evaluated with behavioral techniques. And even some older children are very difficult to test. We've all had experience with these children, and that's where we must rely on the objective test. Some children, for example, children who may be getting chemotherapy, receiving chemotherapy for inoperable brain tumors, simply can't be evaluated behaviorally. They're just too sick. They can't focus on the task, and they've got other more serious concerns. Those are perfect candidates for objective tests. Of course, because objective tests are not influenced by sedation or anesthesia, we can actually perform the test when the child is sleeping. And we can't do that with behavioral audiometry. And of course, the objective tests such as ABR and OEs have permitted automated hearing screening. Hearing screening by non-audiologists, where the machine itself is determining whether the patient passes or fails. So there are many advantages of objective tests. We should be using them in each and every patient, but we rely on them almost exclusively in infants under the age of 6 months. Now, if you begin your assessment, whether it's an adult or child, with objective tests, it's a much more efficient way of evaluating hearing. And I mentioned this in my first lecture on promoting healthy hearing. If you begin your assessment with tympanometry and acoustic reflexes and OAEs, by the time you walk into that sound booth, you should have a very good idea, a very good suspicion of what you will be finding on behavioral tests. In other words, you'll know whether or not the auditory system is most likely normal or whether there's an abnormality. You'll probably know whether there's a sensory or a conductive loss, and you'll certainly be able to distinguish a false hearing loss or exaggerated hearing loss from a valid audiogram if you start out with these objective tests. So I encourage you all to put more emphasis on these objective tests. That doesn't mean you're going to exclude the behavioral test. You're just expanding your test battery. And you can do that and save time because these are all very quick tests that require very little test time. Okay, we covered oral emittance measurements rather completely in my first lecture. And so what I'm going to do here is focus on their applications, the applications of tympanometry and acoustic reflexes in children, infants and young children. Now in the United States, and most of you are probably very familiar with the Joint Committee on Infant Hearing, in the United States, this group, it's a multidisciplinary group. It includes otolaryngologists, pediatricians, audiologists, speech pathologists, educators of the hearing impaired, even some parents and some people interested in statistics. This multidisciplinary group has put together an evidence-based clinical practice guideline. So you can find this online. I put the website there. If you just Google Joint Committee on Infant Hearing 2009 statement, you'll find a PDF version right away. It was published in a journal, the Journal of Early Hearing Detection and Intervention, which is entirely focused on hearing in children and identification and diagnosis of hearing in children. So even though this guideline was developed in the United States, many countries, many audiologists in other countries have adapted it to their culture and their environment. So it's all evidence-based, it's all based on research, and I encourage you to become familiar with it. It really provides you with a template or an overall guide to how you should identify, diagnose, and manage hearing loss in infants and young children. Well, the guideline, the 2019 Joint Committee on Infant Hearing Guideline, basically states that oral emittance measurements, tympanometry and acoustic reflexes, are an essential part of the pediatric test battery. Now, this is all based on research. This is not just a group of people making up some recommendations. This is based on solid research findings. So the Joint Committee says every child, certainly up to age 6 months and even beyond to 2 years, every child should undergo tympanometry and acoustic reflex measurement. Not just tympanometry, both. And as I emphasized in my first lecture, acoustic reflex measurement can be extremely valuable diagnostically. And it's the first real measure of the entire auditory system up through the brainstem. So in addition to the ABR, acoustic reflex measurement can provide valuable information on for the diagnosis and management of hearing loss in infants. Tympanometry, of course, is one of the tests within the category of oral emittance measurements. And for infants under the age of 6 months, it's very important to utilize both low-frequency probe tone and a high-frequency probe tone. A low-frequency probe tone alone is not adequate for evaluating middle ear function in infants under the age of 6 months. So, and this has been very well supported by the literature. There's no doubt that if you use only a low-frequency probe tone of 226 Hz, it is possible to record what looks like a normal tympanogram in a child with abnormal middle ear function. It's a false negative finding. So it's very important to use both low-frequency and high-frequency probe tone. The low-frequency probe tone in an infant is used to calculate ear canal volume. The high-frequency probe tone actually measures the function of the middle ear. And I think most of you are familiar with this, but it's always important to emphasize when you purchase a piece of equipment, obviously, if you're going to be seeing infants, you must have the high-frequency probe tone option. Now, in my earlier lecture, I reviewed acoustic reflexes in some detail. They are very important in infants and young children because they're not affected by the child's chronological age. They're not affected by the child's neurological development or maturation. They're not affected by whether the child's asleep or awake. So the acoustic reflex allows us to very quickly, within minutes, and very objectively and very conclusively document whether the child's auditory system is normal or abnormal, and we can even often determine where in the auditory system the problem might exist, whether it's in the periphery, the auditory nerve, or the brainstem. Probably the most useful of the acoustic reflex measurements, remember I talked about 4 of them, the most useful is probably the acoustic reflex threshold, that very simple measurement of the lowest intensity level that produces a change in the compliance or the stiffness of the middle ear system. And of course, the stiffness in the middle ear system following the presentation of a stimulus that's resulting from the contraction of the stapedius muscle. As I mentioned in my first lecture, one of the simplest applications of acoustic reflex measurement is simply to detect even subtle, very slight middle ear dysfunction, or to rule out middle ear dysfunction. That's very valuable in an infant undergoing a hearing assessment, because if the child has normal middle ear function, then we don't need to worry about referring the child for medical management of a middle ear abnormality. We can focus on a permanent hearing loss and managing that hearing loss perhaps with hearing aids or even a cochlear implant. So that's one of the very valuable clinical applications of acoustic reflexes in infants and young children. We can also, as I mentioned in my earlier lecture, help to, with acoustic reflexes for broadband noise stimulus, we can sort out children who have probably normal cochlear function from children who have a sensory hearing loss. We can objectively estimate hearing status, at least differentiating normal from abnormal. And that's very valuable in determining which children need an auditory brainstem response, and perhaps even which children need to have an auditory brainstem response while they're under general anesthesia. And then the acoustic reflex also is extremely important as a tool to identify children with auditory neuropathy. If, for example, we have a child with normal otoacoustic emissions, the amplitudes are well within a normal range, normal tympanometry, but no acoustic reflexes, that child is at considerable risk for auditory neuropathy spectrum disorder. Even though we don't have any other test results, we are very suspicious. That child with normal OAEs and no acoustic reflexes may very well have a neural disorder. So again, I can't emphasize too much, I can't overemphasize the importance of acoustic reflex measurement. I've already mentioned the value of OAEs in detecting or ruling out very, very minor middle ear problems, so I won't talk about that here. Remember, if the OAE, the acoustic reflexes are abnormal with the probe in one ear, that coupled with an abnormal tympanogram is 100% confirmation of a middle ear disorder in a child. And that would require, of course, it could be bilateral. It could be abnormal tympanograms in each ear, no acoustic reflexes for ipsi or contra in either ear. Those children almost always need to be referred on for medical management, at least initially. Now, I talked about objective documentation of auditory function, cochlear function, in my first lecture, but let me emphasize that here because this is evaluating infants and evaluating young children with acoustic reflexes is such a quick way to rule out any hearing loss that we need to be concerned about, or to confirm there is a hearing loss that we need to evaluate further, usually with ABR. So I showed you this diagram in the first lecture just to refresh your memory. The broadband noise reflex the threshold tends to increase as a child's hearing loss increases. Conversely, if a child has a broadband noise acoustic reflex threshold, even an ipsilateral threshold of better than 80 dB, then there's very little chance that that child has a hearing loss in that ear, sensory hearing loss. Well, let me give you some evidence in support of that statement. This fellow here, Joseph Kai from Australia, the University of Queensland, conducted a fantastic study, just a little study, but very, very practical, very clinically useful. It was back in 2012. He performed acoustic reflex measurement on 66 full-term infants. In other words, they were born when they should have been born at 40 weeks gestational age. He used a 1,000 hertz probe tone, which you would do for infants, and he used both tones and broadband noise stimuli. Well, the first point first finding that was valuable is all the neonates had acoustic reflexes. So you can record acoustic reflexes from any child of any age, even newborns. Of course, you have to first verify that the middle ear is normal. And then what Dr. Kai did was he looked at the acoustic reflex threshold for the different stimuli, including broadband noise. And as you see here, the average or median acoustic reflex threshold for broadband noise was 55 dB, much lower than the acoustic reflex thresholds for tones. And you can see the range was only from 50 to 75. So this is again confirming my earlier statement. If the broadband noise reflex threshold is less than 80 dB, and certainly if it's in the 60 to 65 dB range, then there's virtually no chance of a cochlear hearing loss. Remember, all these infants had normal hearing sensitivity based on the ABR. So I encourage you all to include acoustic reflexes in your test battery for infants and young children. And if you have to use one frequency, even for ipsilateral, just takes a few seconds, or one stimulus, I should say, that stimulus should be broadband noise. Okay, the other application of acoustic reflexes that are so important in infants, as I've already mentioned, is the diagnosis of auditory neuropathy. Now, many of you may not have ABR. You don't have it in your clinic. But if you have acoustic reflexes and you have OAEs, you can at least identify children who are most likely to be diagnosed with auditory neuropathy. The research shows that acoustic reflexes, that OAEs being present or normal always, and absent, the reflexes are absent. So there's no acoustic reflexes, but the OAEs are normal, is a very, very convincing set of evidence or combination of findings for a child with auditory neuropathy. And now many people say, well, auditory neuropathy is quite uncommon. Well, it turns out it really isn't that uncommon. 5% of children with hearing loss have hearing loss because of auditory neuropathy. That's the diagnosis, 5 out of 100. And the greater the degree of hearing loss, the more likely the underlying etiology is auditory neuropathy. So here's my advice, and we'll talk more about this in part 2 of this lecture, but my advice is assume that every child you evaluate, every infant that you evaluate for the first time, they've never had a hearing test, you're evaluating them for the first time, assume they have auditory neuropathy until you prove they don't have auditory neuropathy. That way you'll never misdiagnose a child with auditory neuropathy. Okay, now we're going to move on to otoacoustic emissions. We've just talked about oral emittance. This will be very brief because we've already covered the topic rather extensively in the first lecture. OAEs, as you know, were discovered in 1978 by David Kemp, and for many years, up until, well, for 20 years really, until the late 1990s, this simple way of categorizing OAEs was followed by all audiologists. There were basically two general types of OAEs according to these categories or this taxonomy. There were the spontaneous OAEs, which were always in the ear canal, even without a stimulus of some people. And then there were the stimulus-evoked OAEs, where a stimulus was necessary to elicit the OAE. And within the stimulus-evoked category, you mostly had transients and distortion products. So the implication here was that all of the stimulus-evoked OAEs were quite similar, or just needed a stimulus to actually record them. And then the spontaneous OAEs were different. Well, it turns out that this very simple, it really wasn't evidence-based. It was just kind of a convenient way of categorizing OAEs based on whether there was a stimulus or not. It really wasn't accurate. And these researchers that you see here, Scher and Guinan, in the late 1990s, they started really focusing closely on the mechanisms, the ways these OAEs were generated, and they found that actually this is totally wrong, this category. There's another way of looking at OAEs that's more evidence-based. These researchers theorized, and this has since been proven, that there are basically two types of OAEs, not based on the stimulus, but based on the mechanisms. One of the reflection source OAEs. So a stimulus is presented to the ear, very often a transient stimulus like a click, and what is recorded are essentially reflections of what's happening in the cochlea based on whether the hair cells are functioning or not. And if there are perfectly normal hair cells, there will be some irregularities in the hair cells from one part of the cochlea to the next. Even hair cells right near each other on the basilar membrane may not be functioning quite the same. This is normal. We all know there can be dips in the audiogram, dips in the DP-gram, and there can even be dead spots in the cochlea, which are not clinically important, but they can be documented. So these irregularities in the cochlear function contribute to reflections of the energy back into the ear canal. So these reflection source emissions, the best example of that is transient OAEs. The other general category of OAEs with this approach is distortion product emissions, which obviously are DPOAEs. And here there are two stimuli that activate a very narrow region of the cochlea, hair cells in a very narrow frequency region, but there are two stimuli, and those two stimuli activate the cochlea, and there's kind of an interaction in the traveling wave for those two stimuli, and so there's actually energy at a third frequency, and maybe many more frequencies. So there are distortion products that are being produced by activation of the cochlea with two very closely spaced pure tones. Now this has been known, distortion products have been known actually for hundreds of years, but now we're actually talking about measuring them in the ear canal with a very sensitive microphone. So this is one type of OAE, distortion product, and the other is transient. Now why am I spending some time talking about this? Well, based on this explanation for the two types of OAEs, we probably should be recording transient OAEs and distortion product OAEs more often. Now, in many cases, one OAE type or the other is adequate. But if we have a complex case where the findings, remember the cross-check principle, the findings of various tests are not all fitting together, I encourage you to record both transient and DPOAEs from the same baby. And to adequately evaluate the cochlea. And with many pieces of equipment, of course, it's possible to record both types of OAEs. So OAEs, we know, are evidence-based. Most audiologists don't use OAEs as often as they should, but my whole emphasis here is that OAEs are an essential component of the test battery for evaluating children. As we discussed in the earlier lecture, it's not adequate to simply say OAEs are present or absent. We should categorize them as either normal, present but abnormal, or absent. One of the most important first steps in recording OAEs with children and with adults is to make sure that the probe is calibrated. So it's really important to put the probe for the OAE system into a hard-walled cavity at the beginning of a clinic day, and to make sure that the probe for the OAE is functioning as it should. Probe assemblies get bumped and jostled and sometimes can fall out of calibration. So it's very important to verify that the probe is calibrated. I've written co-authored a textbook with a colleague, Sumit Dar. We have a whole chapter on calibration in this textbook. It's a very, very important part of OAE measurement. With OAEs, there is a microphone, of course, inside the probe, so we can actually calibrate the intensity of the stimulus in the ear of the person we're testing. That's very different than any other auditory measurement. Typically, we're using standard data for calibrating equipment and not using the patient's ear. But with OAEs, we're actually calibrating the stimulus intensity in the ear. But of course, the probe has to be properly calibrated to do that. Now, in recording OAEs from children, one of the challenges is we need to make sure that there's very little noise in the ear canal. Remember, the OAE is actually a sound that we're recording, a very low intensity sound in the ear canal. So any background noise, ambient noise from the room, the test room, acoustic noise, or physiologically produced noise, breathing, moving, can all obliterate our detection of, or prevent the detection of the OAE. So it's very important to do everything in your power to quiet the baby. A sleeping baby is not necessary for OAEs, but a quiet baby is. And it's also important to make sure that the environment is as quiet as it can be. A tight probe fit, a deep probe fit is a good beginning strategy. Closing the room, the door to the test room, turning off equipment that's not needed, telling everybody in the room to turn off your cell phone, trying to eliminate external sources of sound. Usually all of that is adequate in reducing the noise level in the child's ear canal so that we can actually detect the OAE. I've already really covered this in the first lecture, so I won't go over it, but I encourage you to systematically first verify the noise is adequately low, less than minus 10 dB, and then analyze all frequencies, and with the goal of categorizing the type of OAE finding at the different frequencies. Normal, well within normal limits, the amplitude is above the lower limit for normal. Present, it's there, it's above the noise floor by 6 dB, but it's not normal, or there is no OAE. Now, sometimes in infants and young children, there may be no otoacoustic emission, but not necessarily a cochlear deficit, because remember, the stimulus must go through the ear, down the ear canal to the eardrum, and the stimulus must work its way through the eardrum, through the middle ear to the cochlea. So not all children whose OAEs are absent actually have permanent sensory loss. We first need to rule out technical problems, and we need to rule out blockage or something in the external ear canal or the middle ear that might actually be preventing us from recording OAEs. So that's one reason why tympanometry or wideband reflectance or absorbance is always an important procedure along with OAEs, not just the OAEs alone.
If the OEs are perfectly normal at all frequencies, then of course we assume that the middle ear and the external ear canal are not affecting the OAE. But anytime the OEs are absent, we must rule out middle ear or external ear canal explanations. I mentioned earlier that OAEs are so useful in diagnosing auditory neuropathy. Well, that's not because OAEs are affected by auditory neuropathy. In fact, quite the opposite. OAEs, if a patient has a neural problem, anywhere from the synapse between the inner hair cells up through the auditory nerve to the brainstem, but that same child has perfectly normal cochlea, they should have normal OAEs. OAEs are preneural. They're not dependent on the afferent auditory system. They're not dependent on the auditory nerve or the synapse, the brainstem. And so this is the kind of the physiological reason why OAEs coupled with acoustic reflexes or coupled with ABR are so useful in differentiating sensory hearing loss affecting the ear versus neural hearing loss affecting the nervous system. Now, we've talked about some of the applications of OAEs. Of course, they can be used for hearing screening, but they're extremely valuable in the diagnosis of auditory dysfunction. They're very useful in monitoring patients for ototoxicity because all ototoxic drugs will affect the outer hair cells or affect the cochlea in some way. They're also useful, and we're not talking about that really today, but in preschool screenings and school-age screenings, and of course, as I've already mentioned, in the diagnosis of false or exaggerated hearing loss. So what is the Joint Committee on Infant Hearing, these clinical practice guidelines for infant hearing loss assessment in infants? What do they say about OAEs? Well, it's a required component, as you can see here. Otoacoustic emissions are really an important part of the test battery for evaluating hearing in infants and young children. Okay. And if we come back again to auditory neuropathy, I'm just emphasize that the clinical guidelines for diagnosis of auditory neuropathy also highlight OAEs as an important part of the test battery. All right, we're going to move along now to the next response, and we're going to we're getting close to an hour here, 55 minutes. We're going to move through these responses a little more quickly. The reason for that is that these ASSR, ECOG, cortical responses, they supplement the ABR. The ABR is the gold standard, the workhorse, the main technique that you are going to use to estimate auditory sensitivity, to diagnose hearing loss, and to manage infants and young children. The ABR, along with the OAEs and along with oral emittance, those three objective techniques are what you're going to use most often. These others I refer to them as supplementary or added techniques. Sometimes they're needed, but sometimes they're not. So let's start with the auditory steady state response, abbreviated ASSR. Well, the ASSR is most useful audiologically. And there's other research applications, but as for audiologists, the most important application of ASSR is to estimate hearing threshold at high intensities in children where there is no ABR, or where the ABR is not present is not observed for all frequencies. So once with an ABR, you're using very brief stimuli, transient stimuli, clicks or tone bursts. And because they're very brief, there's not a lot of energy there. So once you get up to 80 or 85 dB of hearing loss, it's sometimes hard to even see a wave 5. And if you do, it may be very small. It may be mixed in with the background noise. And yet the child may still have some hearing. You know, a child with hearing thresholds of 80, 85 dB could very well benefit from a hearing aid. And certainly if the child has hearing thresholds of 90 dB, you may not see an ABR at all, and yet they still are hearing sound. It's not like they're deaf or profoundly hearing impaired. Now the ASSR, the traditional ASSR, it does not use clicks or tone burst as the stimuli. The traditional ASSR is a pure tone that's amplitude modulated. That is, the amplitude of the pure tone is quickly modulated. It's an AM signal, and sometimes the frequency is modulated a slight bit, maybe 10%. So the frequency kind of, it's like a warble tone, kind of varies around the test frequency. And therefore, if it's a pure tone, there's much more energy because it's a longer duration stimulus. So with the ASSR, you can actually sometimes estimate thresholds of 110, 115, maybe even 120 dB. Now, if you have no ASSR, no ABR, even at the maximum intensity levels, and you go to ASSR, and now there's no ASSR, you can't see an ASSR, or that you see it. The machine tells you no response at 120 dB. Now you know a hearing aid is not going to help this child. So an ASSR, the absence of an ASSR and ABR, almost always indicates that the child will need a cochlear implant, or at least it tells you that they're not going to benefit from amplification. So that's the big advantage of using ASSR, estimating severe profound hearing loss. Now there are other advantages because the ASSR systems depend on a statistical verification, a statistical determination of a response. So for someone who doesn't know much about ABR, doesn't have the experience in recording and analyzing ABR, the ASSR is attractive because once you put the electrodes in place and the earphones on, the machine, the software, will actually confirm that there's a response. So there are really two applications of ASSR. One would be confirming the ABR results or going beyond the ABR results with higher intensities. The other application of ASSR is for people who don't have much experience with electrophysiology to actually estimate hearing threshold accurately. Ultimately, our goal is to find hearing threshold, audibility, for the major regions in the speech frequencies. So we want to estimate hearing sensitivity somewhere down the low frequency region, 500, mid frequency region, 1,000, 2,000, and then we want to estimate hearing thresholds in the highest frequencies, around 4,000, and that way we have some information which we need to amplify the speech spectrum, amplify all speech sounds so that the child can hear them all. So we want audibility for the child across the speech spectrum. That's our goal, and that's really what this entire lecture is all about. So as I mentioned, the traditional pure tone, traditional ASSR stimulus is a pure tone that's rapidly modulated in amplitude and usually slightly modulated in frequency. So here's a 2,000 hertz tone that's reaching the 2,000 hertz part of the cochlea, and of course if the child can hear, it's activating the brain at 2,000 hertz, but also it's being rapidly modulated in amplitude. You can see the amplitude goes up and down very quickly, 100 times per second, 100 hertz. So in that child's ear, we've got activation of the 2,000 hertz part of the cochlea, but in their brain, there's energy at 1,000 hertz. I keep saying 1,000, at 100 hertz. There's energy at 100 hertz, 100 times per second. This amplitude is being modulated. Now, the brain doesn't normally have energy at 100 hertz. The normal EEG in a person is somewhere between 0 and 30 hertz. So the machine, the ASSR device, is detecting brain activity with electrodes and in some way documenting that there's brain activity in response to this stimulus. And if there were no stimulus, that brain activity would not be there. Or if the patient had a severe hearing loss and wasn't responding to the stimulus. Now, we could talk a lot more about ASSR, but I want to just quickly point out that there is quite a bit of new research using ASSR measurements evoked by chirp stimuli, the same chirp stimuli that we're talking about for ABR. And of course, the ABR wave 5 is much bigger for chirp stimuli, and so is the ASSR. So the chirp stimuli are more effective stimuli, not just for ABR, but for ASSR. So there are now probably a dozen, maybe even 20 articles describing the benefits of using chirp stimuli with ASSR. So ask the manufacturers whether the ABR system that you're looking at has chirp stimuli, and then of course whether they can be used for ASSR. So here's a study, 2015, showing the correlation between ABR thresholds and ASSR thresholds, and then also ASSR thresholds and behavior thresholds. And you can see there's a very strong correlation. Now, I would prefer to use both ABR and ASSR, not ASSR alone, because I use ABR to evaluate the patient neurologically. I look for the wave 1, the wave 1 to 3, the wave 1 to 5 latencies. I also use bone conduction stimuli with ABR because I know if I can detect a wave 1 with bone conduction ABR, I know which ear I'm testing. But then I feel very comfortable using ASSR to estimate thresholds for tones or very high intensity thresholds or severe loss if the ABR is not present. Another big advantage of ASSR with chirps is the speed at which the ASSR is detected. And remember, it's automatically detected by statistical program. So here's another study from 2013 showing that the sleeping child, a child who's sleeping while the ASSR is being done, can be tested incredibly quickly. The time it takes to detect an ASSR is down around 20 seconds or less. So you could quickly drop down from a higher level, detect the response, quickly find threshold in a matter of a minute per frequency. And so you can easily see where you could, with 4 frequencies per ear, a minute per frequency, 10 to 15 minutes is all it would take in a sleeping child. Even in a child who's awake, it's still possible to find, to record a single ASSR at 1 intensity level in less than, well under a minute. So this is, the chirp stimuli speed the process up. If you want a nice overview of this concept of using chirp stimuli and quickly estimating thresholds, both for ABR or with ASSR, here's an excellent article by some experts and well-known electrophysiology people, Yvonne Sinninger and others, showing how quickly this technique works using chirp stimuli. And here's just one more little figure showing, again, that you can detect ABRs and, in particular, ASSRs in a matter of seconds. So the test time for a baby is so brief that it might be possible to get all the information you need for both ears in a baby who's not sedated in a matter of, in the time that they're sleeping, even if it's only 15 or 20 minutes. Okay, now one last point before we move on to the ECOG. We must have a quiet baby. The most important thing you can do, aside from using an evidence-based protocol, the most important thing you can do to record a high-quality ABR in your patient is to have the patient as quiet as they can possibly be. And with children, with infants and young children, sleeping is really the best state. You want the child sleeping either naturally or in some other way. You want to eliminate all electrical artifact that you can, and we really haven't had much chance to talk about that, but you want to eliminate electrical artifact that has nothing to do with the patient's brain activity that you're trying to record. In fact, you want to even eliminate brain activity through filtering that won't contribute to the response that you're recording. So you're trying to optimize the measurement conditions. Very little or no electrical artifact, little or no myogenic muscle artifact, and as much emphasis on the actual frequencies of the response that you're recording. And it can be done, but it takes a little it's challenging. And the biggest thing you can do really is to assure that your baby is sleeping as quietly as possible. So how do you do that? Well, one option is natural sleep. So you do everything that we talked about earlier, everything you can to deprive the child of sleep the night before and right up until the test, and then allow the child to sleep. Most children who have been deprived of sleep and who are then fed and who are in a quiet place or in their mother's arms or in a very secure environment they will sleep deeply. Of course, the younger the child, the younger the infant, the more likely they will fall into deep sleep. So sleep deprivation and natural sleep does work for more than 50% of all babies. And the younger the infant, the more likely you will be able to record a quality ABR with very little background noise, very little muscle movement in any environment, whether you're in the clinic or wherever you might be. Now, another option is anesthesia. Of course, there's a third option, and that is light sedation. And in the United States, we used to use chloral hydrate. I'm not sure if it's still available in Russia. In the United States, chloral hydrate was used for many years. We used it all from the 1970s right up through the 80s and into the 90s, but it became less available. There was one manufacturer who wasn't making enough of chloral hydrate. Anesthesiologists didn't like to use it because it took so long for the child to fall asleep and it was so easy for them to wake up that there was a move toward just using light anesthetic, an anesthetic like propofol. So in the United States, most audiologists go straight from trying to perform an unsedated natural sleep ABR, and if that doesn't work, if the child never does remain quiet, we go straight to light anesthesia. Okay, ECOG. Now, I'm not going to spend too much time on it. I'm going to emphasize the value of ECOG above and beyond ABR. As I've already mentioned, I've got this e-handbook of auditory evoked responses, which you can find online, and it has chapters, 2 chapters on ECOG, plus an introductory chapter on all evoked responses, which also mentions ECOG. So I encourage you to read more about electrocochleography. Don't rely entirely on this one lecture. ECOG was first described in 1930. It's the oldest of all auditory evoked responses. The primary person who discovered it was Glenn Weaver, who was a very well-known basic hearing scientist in the 1930s and 1940s. There are 3 main components or generators of electrocochleography. Obviously, the name implies we're recording an electrical response from the cochlea, and that is the case. The cochlear microphonic is an electrical response that's generated at the very top or apex of the outer hair cells. And when the stereocilia on the outer hair cells are deformed or bend, they produce what's called a receptor potential. It's an electrical potential at the top of the outer hair cells, and that is actually contributing mostly to the cochlear microphonic. So that's a representative, or that's a generator that's kind of similar to OAE's, outer hair cell. Summiting potential, for many years we knew it was arising from the organ of Corti in the cochlea. Nobody knew exactly where, but research where the inner showing, or research conducted with animals where the inner hair cells were damaged, tended to eliminate the summiting potential. And so that research led to the conclusion that most of the summiting potential energy is due to activity of the inner hair cells. So cochlear microphonic, mostly outer hair cells. Summiting potential, mostly inner hair cells. The action potential is really technically not a cochlear response. It's arising from that region, but it's arising from the afferent, the afferent or ascending auditory nerve fibers as they leave the inner hair cells, as they leave the synapse, and where the inner hair cells synapsing with the nerve fibers. So it's in the spiral ganglion. It's definitely in the cochlear region, but it's a neural response. So these are the 3 main components. The abbreviations are CM, SP, and AP. Now, ECOG is recorded very similarly to ABR. Basically, you take an ABR protocol and make a few minor modifications. You change some things like the filter settings, you include lower frequencies, but the most important change between an ABR protocol and an ECOG protocol is where you place the inverting electrode. And the basic principle here is the closer that you can get the inverting electrode to the cochlea itself, the better the response. Technically, a real ECOG is recorded only when the electrode is right within the electrical field produced by the auditory nerves in the cochlea. So the best, by far, the best approach for recording ECOG is to place a needle through the eardrum and with the tip of the needle on the promontory, because now you're within a millimeter of these structures. For audiologists who are not physicians and not surgeons, then the next best approach would be to put an electrode on the tympanic membrane. A very non-invasive approach where a soft electrode is placed up against the tympanic membrane. Then the least attractive option, which is really technically not even an ECOG response, is to have an electrode out in the ear canal. So let's just review each of these electrode options in a little more detail, because that's the most important aspect of recording electrocochleography. There are several tympanic membrane electrodes available to audiologists. Again, they're non-invasive. This is within the scope of practice for a non-physician audiologist. And this is one of them. It's named after a very well-known audiologist who developed it, David Lilly. It's called the TM Wick electrode. The TM stands for tympanic membrane, and the wick means that you take this little piece of cotton that's tied to or connected to a silver wire and leads eventually to a normal electrode wire, and you soak that cotton in saline. And so the saline soaks, or is like the cotton's like a wick. It soaks the saline or absorbs the saline, and that's all mushed up against the tympanic membrane. It's a very flexible wire, so you're not going to press this through the eardrum, and then you just connect a regular electrode cable to the other end. And this is held in place with an insert earphone cushion. Here's another version. You can get online and you can Google tympanic membrane electrodes. Here's another one from a big electrode company, Sanibel. And this is a slightly different version, where at the very end there's a thick gel. It's not a gooey gel, it's kind of thick. It rests up against, it's very soft, rests up against the tympanic membrane and conducts any electrical activity from the ear. Now it's being connected through skin and through all the structures connecting the tympanic membrane to the cochlea, and probably through the air as well, and through any fluids. So it's not right at the cochlea, but it still produces a pretty good sized electrocochleography. By far the best approach by far is a needle. And years ago, in the 1990s, working closely with an otologist, we developed a technique for transtympanic ECOG that uses just regular subdermal needle electrodes that you'll find in any operating room. Now this can also be done in the clinic. If the eardrum is numbed or anesthetized with phenol or some topical anesthetic, then this electrode can be slipped right through the lower posterior inferior quadrant of the eardrum, straight back to the promontory. It's held in place, as you can see with the figure to the right, with a foam plug that is deep in the ear canal, keeping the electrode cable in place. And that'll stay there all through the ECOG test. It's very, very stable. In the operating room, this needle is inserted with bayonet forceps, again through the lower back portion or posterior portion of the eardrum, right against the promontory while the patient's anesthetized. So this is great for intraoperative monitoring, but it's also great for ECOG. And if you're performing ECOG on a child who needs to be in the operating room for some reason, needs to be sedated or anesthetized, this is definitely an option. Or you could use the tympanic membrane electrode. If anybody's interested in this the simple technique for inserting or using subdermal needle electrodes for ECOG, just send me an email and I'll send you a copy of an article we published way back in 1990 describing this technique. One of the big advantages, of course, of using a transtympanic needle electrode is the size of the response. It's very big. Whereas with a ABR, the wave 1 may only be 0.2 or zero point 0.3 microvolts, just half of the size of wave 5. Wave 5 is about 0.5 microvolts, half of a millionth of a volt, and wave 1 is usually half of that, so 0.2, 0.25. When you get to using a transtympanic needle, right, which is, I mean, on the promontory, it's very, very close to the cochlea itself and the auditory nerve fibers, you can record responses. A wave 1 of the ABR might be 10 microvolts, 20 microvolts, might be 100 times bigger sometimes than what you would record using an electrode on the earlobe or the mastoid. And here's a good example. The top waveforms are in the operating room before and after surgery using ear canal electrode, inverting electrode, whereas the bottom tracings are transtympanic. And they're just so clear and so large. Okay, well, when do you want to use ECOG in children? What's the biggest application? Well, there's no question about it. The biggest application is when you suspect auditory neuropathy spectrum disorder. So if you have a child with normal OAEs and yet they have no acoustic reflexes, normal OAEs and no ABR, or only cochlear microphonic and no ABR, then you're suspecting auditory neuropathy. That's when ECOG is very, very important, because if there's any question about where the site of dysfunction is, the site of dysfunction that's producing this auditory neuropathy, ECOG can help resolve that. So ECOG is described very clearly in the clinical guidelines for the diagnosis and management of ANSD. Here are the guidelines that you just saw, 2010 guidelines. And of course, OAEs are already, we know, are an important part of the guidelines, but so is ECOG. And you really are looking for a cochlear microphonic indicating that the hair cells are normal, and then looking for the action potential or summiting potential to differentiate between inner hair cell or auditory nerve dysfunction. Now, we mentioned this earlier when we were talking about the acoustic reflex. Auditory neuropathy is not as uncommon as we all used to think. We didn't identify it accurately many times, so we thought that it wasn't very common, but we were missing many of the cases. So it turns out that if you take all the children who do not pass a hearing screening and then who also are confirmed with a hearing loss, this is just every child, not just those from the intensive care unit, but these are children from the well baby nursery, that even in that population, you may be dealing with a prevalence of around 6 to 6.5%. So of all hearing loss, even healthy babies, 6 to 7% actually are due to auditory neuropathy. And that's been proven. This is two different studies, both showing the same data. Right around 6 to 7% of all babies with hearing loss who are healthy, otherwise healthy. When you get into the intensive care nursery population, then of course you see more auditory neuropathy. More babies with hyperbilirubinemia, more babies with asphyxia, more very premature babies. And of course there's a big genetic factor. Perhaps up to 50% of all auditory neuropathy is related to genetic causes. So what is our goal here? Our goal with ECOG is to identify which part of the ear, which part of this peripheral auditory system is actually abnormal and what's working normally. The outer hair cells, typically in pure auditory neuropathy, are functioning well. So the problem is usually either presynaptic, which involves the release of the neurotransmitter at the bottom of the inner hair cell. So it's technically an inner hair cell problem, but it's not that the inner hair cells themselves are not functioning, it's they're not producing the neurotransmitter that is necessary for hearing. Or is the problem postsynaptic? Is it in the nerve, and are the hair cells, inner and outer, normal? And distinguishing between those two is very important, because we must have that information to confidently manage a child with the cochlear implant. If the auditory nerve does not exist, if the auditory nerve is simply not functioning, then a cochlear implant is not likely to help the child. With ECOG, we can help to determine whether the etiology of the auditory neuropathy is presynaptic or postsynaptic. I strongly recommend, if you want to read more about auditory neuropathy, this wonderful article by Gary Rentz and Arnold Starr in 2015. And this is a table from that article in Brain where they very clearly delineate ECOG patterns, etiologies, underlying causes of auditory neuropathy, and these different categories of auditory neuropathy that I just mentioned. Okay, we're leaving ECOG now. We're going to finish this lecture with a quick review of cortical auditory evoked responses. And I'm not going to spend much time. I know this has been a long lecture. We're going to be coming up on an hour and a half. The reason cortical auditory evoked responses are important in infants and young children is usually not to diagnose hearing loss. We can do that with ABR. We can do that with OAEs and oral emittance measurements, tympanometry, acoustic reflexes, and of course also with ASSR and ECOG. Cortical evoked responses, though, are valuable because they give us information on the highest levels of the brain, in the temporal lobe, Heschel's gyrus, and the secondary auditory areas. Now, most of the time, we're not too concerned about the integrity of those areas. We're more interested in the ear. We're more interested in beginning intervention with hearing aids or cochlear implants. But once we've determined that the child has a peripheral hearing loss and they need to have amplification or cochlear implants, cortical evoked responses can help us determine whether or not the cochlear implant or hearing aid is helping the child. It can help us to document maturation or development of the highest levels of the brain, which are obviously essential for a child to speak and to have language. So we're not so much using these responses for diagnosis, although they could contribute to diagnosis in some cases. They're more used to document the effectiveness of intervention. And that documentation is critical. Rather than waiting 2 to 3 years and finding out, wait, the hearing aids aren't helping the child's still not speaking. Well, then it's too late. The child has missed out on all that auditory stimulation, and the auditory regions of the brain are going to have a hard time ever functioning as they should. The time to determine that hearing aids may not be the best management option is within a month or two of beginning of hearing aid use. If the brain is not starting to show some rapid development and maturation with amplification, then it's likely that the hearing aids are not helping the child. And we can document that cortical maturation or development very, very quickly with auditory evoked responses. So for the most part, we're interested in 3 cortical responses: the auditory middle latency, the auditory late response, and the P300. Now we can't go over all the details of these responses. They're in my e-handbook of auditory evoked responses. But I'm just going to quickly review these to get to the point of how we can use them in infants and young children to document the benefits of intervention. So the middle latency response in an adult or an older child, 10 and older, looks like this. There's a PA component around 25 milliseconds and then another prominent PB component around 50 milliseconds. And we want to make sure we're not confusing this middle latency response discovered back in 1958. We're not confusing it with a post-auricular artifact, which occurs at a much earlier latency, earlier than 20 milliseconds. Now, I stress that this is the response in an older child or an adult. In an infant or a young child, we don't see this entire response. We only really often see the PB component, and we record it at a much later latency than 50 milliseconds. We do know that the middle latency response arises from structures in the thalamus, the pathways from the thalamus to the cortex, auditory cortex, and the primary auditory cortex. So we know it's a thalamico-cortical response, and the PA and PB components are definitely arising from the auditory cortex. In an older child and an adult, the auditory late response, the next longer response, it looks like this. And this is well known. Most of you have seen this. Many of you have recorded it. You can certainly use speech stimuli. There's an N1 component, a P2, which is around 100 milliseconds, P2 around 200 milliseconds, and they're very large. They can be up to 10 microvolts in size. Now, this is not going to be recorded, typically not looking like this, in an infant or a young child. So when you see cortical evoked responses being described in infants, it's typically the middle latency response, but it's occurring later out in the range where you typically see a late response. So these are some of the applications that I just mentioned, really, for use of cortical responses in infants and young children. The most important is documenting that the management is effective, whatever the management is, cochlear implants or hearing aids. There is another application, and I've certainly used the later responses, cortical responses, in this way, because they're elicited with not clicks or tone bursts, but tones or even speech. The cortical responses can be very helpful in documenting auditory neuropathy spectrum disorder, in particularly if you've got no ABR because of problems with the synchronous firing of the neurons. And you're wondering, is the auditory nerve even functioning? I mean, the ABR is absent. We've got cochlear microphonicus present, maybe OAEs, but there's no ABR. Is anything getting up the nerve to the brain? We can use these longer latency cortical responses with longer duration stimuli and with speech stimuli. And sometimes you will actually record, it'll be delayed in latency, but you'll record a cortical response even in a child with no ABR. And now they have a hearing loss. You have to be at a very high intensity level, or you might even be using electrical stimulation to record the cortical response. But in any event, that cortical response confirms that that auditory nerve is functioning. It's transmitting information up to the brain. So we're not going to be using cortical evoked responses on every infant and young child. We will be using ABR on every infant and young child, but they do play a role, along with ECOG and along with ASSR.
Well, we've come to the end of the lecture on update on objective assessment of hearing in infants and young children. I hope this information has been useful to you, and I hope you apply it in your clinical practice. If you want more information on this topic, these are two references that I've published. On the left, you see the e-handbook of auditory evoked responses, which you can download from the intranet via amazon.com. And on the right is a textbook that I've written for all audiologists, from students to practicing audiologists. It's entitled Introduction to Audiology Today. And that also, this book also can be acquired from the internet, either in hard copy or a Kindle version. And it covers topics that go way beyond objective assessment of hearing, but I do address that topic in this lecture. So again, this topic, objective assessment of infant hearing or hearing in infants and young children, this PowerPoint presentation is meant to complement or go along with the workshop on the auditory brainstem response. I hope it's been of value to you.